Okay, now I'm really ready. So we're kind of in the middle of bone, and I like bone for a couple of reasons. First of all, I like bone tissue. I think it's interesting. I like tissue. It just is. What can I say? I'm weird that way. But more importantly, there's some physiology. We finally get into some real physiology here. So you get your first taste of those feedback loops that get confusing, but they get easier the more you do them. So I try to build in a lot of that so that you get good at it. So I want to come back to this picture because there's a couple of things that we didn't pick up at the time when we were looking at it yesterday. So one of the things is that you have the periosteum here. Now, y'all learned that in lab, didn't you? Did you get to see a fresh one? We used to be able to bring fresh bone in. There's this really nice meat market over on Front Street. If you're from around here, you know the country meat market. Y'all know? If you don't, you should go sometime. It's awesome. All that being said, they used to cut bones for us. They used to do that. And I think insurance liability and stuff, bone saws are kind of difficult to deal with. So it's hard for us to get fresh tissues anymore. So once again, you're stuck going home and messing with raw chicken, like I told you yesterday. See if you can't peel loose that fibrous covering over a bone. It's really tough. I mean, they're connected by fibers, collagen fibers, but it does give you some sense of it. But the other thing is this is one of our connective tissue membranes. So let's remember what that means. For something to be a membrane, what did it have to have? It has to be 2 layers of 2 different kinds of tissues. This is a connective tissue membrane. So the 2 kinds of tissue have to both be connective tissues. If one of them was an epithelial tissue, then it would be an epithelial membrane. So what do we have? We have a fibrous layer and a cellular layer. And if you look at those in more detail, which is kind of hard to do, but you can look at it when you look at it in your book and read about it in your book, then what you'll see is that the cellular layer is a layer of bone cells. So it's bone tissue. Whereas the fibrous layer is an irregular, collagenous, dense connective tissue. It's continuous with the fibrous capsule over the joint, and it's the same kind of tissue as that. So you have a layer of fibrous connective tissue welded to a layer of bone tissue, and that bone tissue is distinct and can be peeled off from the bone itself. Not easily, but it can be. You also have the fibers, the perforating fibers, which are the collagen fibers that lead directly from the periosteum into the bone. It is really hard to take it off. If you cook your bone first, it might be a little easier. I don't know. But it's not a simple thing to do. So they're very, very tightly connected as you would expect them to be. I think the last thing we said last time was about how vascular bone tissue is. And some of you seemed surprised that we describe bone tissue as being highly vascularized. But if you compare bone tissue to, as soon as it comes in, why is that not working? You compare bone tissue to cartilage, then there you see it in just black and white. So you have avascular is the term we use for cartilage, right? What did that mean? It's got no blood vessels in it at all, because if you put blood vessels in it, first of all, it weakens the tissue, and second of all, they're more likely to get torn or squashed, because cartilage, although it's solid, is rubbery solid, not firm, hard tissue like bone. And so bone, because it's strong enough, does have an extensive blood supply. Okay, and the last thing I remember talking about was that if you break a bone, it can heal. And it can heal because it's got a great blood supply. It's a regenerative tissue. Okay? The terminology of the cells, I think we've gone over enough to where we feel pretty good about that. Am I right? Any questions about osteoblasts versus osteocytes, chondroblasts or chondrocytes? Okay, so we're going to turn our attention briefly to the cartilage itself. And we're going to talk mostly about what happens in the hyaline cartilage, because that's what the embryonic skeleton, not completely, but almost completely begins as. And we're going to see that there are 2 different kinds of growth in cartilage. What does the term interstitial tell you? In between. So it's within the cartilage itself. So if I have a plate of cartilage, if this is a cartilage plate, and there are cells embedded in it, then those cells can divide by mitosis and form new cartilage and expand from within. Okay? That's interstitial. What do you think appositional means? On the outside, so by depositing new layers on the outside. So do you remember that there was a membrane on the outside of cartilage called the perichondrium? Guess what? It's 2 layers, an outer fibrous layer and an inner layer of chondroblasts. And so those chondroblasts are sitting there right in that surface, the perichondrial surface, and they can make new cartilage by adding new layers to the outside. Is everybody okay with the difference between interstitial and appositional? Got it? Can you do interstitial growth in bone? Interstitial, remember what that meant? The cells on the inside can divide by mitosis and expand from within. Cartilage is a rubbery tissue. Bone is hard. You can't expand bone from within. Okay, and in fact, in cartilage, in old cartilage, and everybody in this room has old cartilage, sorry, in old cartilage, you can't do it either. It's just in fresh, young cartilage, like in growing children, or in newly laid down cartilage. Is it still soft enough that it can expand from within? So interstitial growth is associated with cartilage, but not with bone. And interstitial growth can only be done in growing cartilage, not within cartilage that's mature. Any questions about that? Okay, so here you see a diagram. What kind of growth are we seeing in this series of diagrams? What are your choices? Interstitial and appositional. So which one are we seeing here? We are in interstitial growth right there. Okay? It's growing from within. It's completely surrounded by cartilage matrix, but it's still forming new matrix in between the cells and expanding from within. Questions about that? Okay, so in the early embryo, there's a couple of things that you've got to try to visualize. First of all, how big is it? If I'm talking about, let's even go to the end of the embryonic stage. How big is an embryo right before it becomes a fetus, which is at about at 12 to 15 weeks, somewhere in there, 10, 12 weeks maybe? How big is it? It's a little tiny thing from what we call the crown rump length. And you know I'm a bad artist, right? So if this is the head and here's its little body, it's got a big old liver, but never mind that. We don't even try to measure the limbs at this point. So if you're just measuring it from his head to his tail, that's the crown rump length. About like that. About that big. Okay? So if you're looking at bones in that skeleton, how big are the bones? Tiny. And you've got to visualize that. We're working with really, really small structures to begin with. And the cartilage develops first, so the second aspect of this is just to try to remember the cartilage comes first, and then bone replaces it. Sometimes we get lazy and say that the cartilage turns into bone. Not really. It's not like cartilage cells become bone cells. They don't. The cartilage lays down a template, a model, and then it dies, and then bone replaces it. Okay, so cartilage first, bone replaces, but cartilage does not turn into bone. All right, so in early embryonic development, we're going to have both interstitial and appositional growth, and then as the cartilage matures, interstitial growth doesn't work very well anymore because the cartilage is too rigid, and so from that point on, if I want to make something bigger, I'm just adding new layers to the outside. Are we good with that? All right. So then once we have that cartilage template formed, and then it can ossify. And ossification or osteogenesis is the formation of bone. And this process begins, I would say, somewhere around 10 to 12 weeks, somewhere in there. No, maybe earlier than that. 6 to 8 weeks, you get the initial formation of bone cells. It's really hard to see at that point. The screen says 8 to 12, so I'm kind of in the right ballpark. And we have two different ways that bone forms. Look at the last bullet, intramembranous or endochondral. Which one of those do you think involves cartilage? Anything with chondro in the name refers to cartilage. So that your endochondral ossification is the kind I've been telling you about, where the cartilage forms first and the bone replaces it. But there are some bones which do not start out as cartilage. They start out as a fibrous membrane. And here, I think what I want to do is kind of back up a little bit and go over something that we really just didn't talk about before. And that is that in the connective tissues, there's an original connective tissue called mesenchyme. And mesenchyme is embryonic connective tissue. What do you want to call the cells of mesenchyme? If you got to vote, would mesenchymal cells sound good to you? Works. So mesenchymal cells arise in mesoderm, which you remember gives rise to the connective tissues. And mesenchymal cells are kind of star-shaped cells. And they do tend to connect to each other, which should remind you of the fact that bone cells connect to each other. But at some point, these mesenchymal cells are getting some kind of signal. That signal is something we call a growth factor. A growth factor could be a hormone, but it might just be a paracrine secretion. Do y'all remember what that means? A paracrine secretion comes from nearby cells. So there are chemicals that are secreted by cells in the area of a limb bud in an embryo that say grow an arm and put a hand at the end of it. Okay, so those growth factors are stimulating cells of various kinds. And mesenchymal cells can be stimulated to become any of the kinds of connective tissue. So do you remember what the 4 kinds of connective tissue are? Four kinds of connective, what were they? Loose and dense are both one kind. What's the category for loose and dense? Fibrous. It's sometimes called connective tissue proper, but that doesn't really help us much. Loose and dense. What's another kind? Collagenous is a kind of fibrous. Okay, I've been working with you guys on making sure you know what the categories are, all right? Muscle is not a connective tissue. All right, we're going to back up. Y'all are having entirely too much trouble with this. All right, so now let's back up. Name the 4 kinds of tissues. Connective, epithelial. Okay? So if I ask you to name a tissue type, are you going to tell me collagenous or loose? If I'm asking for the 4 basic tissue types, this is it. But if when we get to the connective tissues, I tell you there are 4 kinds of connective tissues, now what are you going to tell me? Cartilage is one. Bone is one. Blood is one. And fibrous. Okay? So does everybody see that distinction between categories? These are the 4 kinds of connective tissues. They all come from the original connective tissue, which was this mesenchymal tissue. So in the embryo, these mesenchymal cells are producing fibers to make a mesenchymal connective tissue, which is a fibrous connective tissue. And then, depending on where in the body it is and what growth factors signal it, it's going to differentiate into fibrous connective tissue or cartilage or bone or the blood-forming tissues. Okay? Are you with me on the big picture now? Okay, so mesenchymal tissue is the original embryonic connective tissue, and it can become any one of these things. So depending on where in the skeleton you are, those mesenchymal cells will either form a fibrous tissue or a cartilage within the skeleton, within what's going to become bone. And so we have two kinds of osteogenesis. What is osteogenesis? Formation of bone. And what are our two kinds? Look at the last bullet. Intramembranous and endochondral. So we either start a bone out as a fibrous membrane made of mesenchymal tissue, or we take mesenchymal tissue, we turn it into cartilage, and then turn that cartilage into bone. Is everybody all right with that so far? Got it? Okay, so in intramembranous, this one's short and sweet. If you start with mesenchymal tissue and turn it directly into bone, then you're going to have these little places within that membrane where the growth factors have come in and told some of those mesenchymal cells to turn into osteoblasts. And they're going to start making bone right there on the spot, right where they're sitting. They turn into bone cells, and they start making bone right within a fibrous membrane. Okay? So they're making bone. We're also going to have some cells that differentiate into osteoprogenitor cells. What do? Those are the stem cells. So those are the ones that are just going to hang back and divide by mitosis periodically to increase the number. Actually, in an embryo, they don't hang back. They're very busy. What's left of my membrane, my fibrous membrane that I started this bone out as, forms the periosteum. So it doesn't go away. It stays on the surface. Okay? Other than that, the process is very similar to what we saw yesterday. Osteoblasts can get trapped in their own matrix and become osteocytes. And eventually, we reorganize that as the blood vessels grow in. Blood vessels are a key to bone growth. You know bones are well vascularized. The arrangement of the blood vessels is not haphazard. It's very specific. But in the early embryonic bones, as they first form, it's not real clear-cut, and we call it woven bone. It's just sort of thrown in there with blood vessels hither and yon, but eventually it's going to reorganize into nicely laid out compact bone and spongy bone. Okay? So there's really not much left to tell about that except to talk about which bones are formed intramembranously. And what we find is that the entire cranial vault is intramembranous. So the big bones of the cranium that you learned, frontal, parietal, temporal, occipital, at least that part of those bones that form part of the cranial wall, that's intramembranous. Now think back to what you learned about those bones, and remember that your temporal bone has the big flat part. It also, of course, has a zygomatic arch, zygomatic process, and it has the part that forms the inner ear, which we call the petrous portion, the rocky portion. I don't think that's on your list. So that's a complex bone, and it actually forms part by one process and part by the other. Occipital bone, likewise. What features did you learn on the occipital bone? The condyles, and there's a big hole there, right? Is that an important big hole? Yeah, pretty important. Raymond Magni. So that part of the occipital bone forms, at least in part, from a cartilage precursor. But the big walls that go around your brain, that starts out in the embryo as just a fibrous membrane. And in fact, the growth of that membrane, and therefore of the bone that comes from it, is based on the growth of the brain. So in these cases of Zika infection, where the Zika virus has infected the growing brain of these very tiny embryos and fetuses, the failure of the brain to grow means the skull won't grow either. They grow hand in hand. So as the brain enlarges, the skull bones enlarge to go with it. Failure of the brain to enlarge means the skull is not getting the signal to get that big. Make sense to everybody? On the other hand, we have cases of hydrocephalus. Does anybody know what that is? Hydro is water and cephalic is brain, so, or a head anyway. So it's water on the brain is the common translation. And we see that in cases where the fluids that float and support the brain, the cerebrospinal fluid, doesn't drain correctly. It's supposed to drain back into the blood. And in children who during development have a failure of that fluid to drain, the fluid accumulates. And that's enough pressure to make the skull continue to grow even though the brain may be quite small. So you could have small brain, big skull, but there's a lot of fluid in between. So it's evidently just the tactile force, the pressure of a growth of the head that makes the skull enlarge. Those skull bones are responding to mechanical pressure somehow. Right? There's one other bone in humans that I think you need to know is intramembranous, and it's a weird one. It's the clavicle. Because that's a weird bone anyway. First of all, it's the only long bone that's not in a limb. Stop and think about that. What do you know about long bones? What's your description or definition of a long bone? We went over this in CAP this morning, a little bit. Some of us did. Can't remember what I said? You know that's why I'm bringing it up, right?
There's something on either end of the bone.
So long bones articulate end to end. They may articulate side by side, but they don't articulate along their shafts. So even where you have the radius and ulna side by side, where's all the articulation? At the bottom and top, at the proximal and distal ends, not along the shaft. There's a membrane there, but the bones don't have, there's not a true joint there. That's probably a misstatement, but close enough. Okay, so what, can you name all your long bones? Can you name them? So in the upper limb, you have humerus, radius, ulna, then you have the metacarpals, and then the phalanges, right? Those are all long bones. So correspondingly in the lower limb, you have femur, you have tibia and fibula. Skip the ankle, go to the foot. You have the metatarsals and the phalanges. So even your little pinky toe bones that are only that long are still classified as long bones. Why? Because of the way they're built, because of the way they articulate. They have a shaft. They have a proximal epiphysis and a distal epiphysis. That's a long bone. Okay? So thinking about the bones in the head, neck, and torso. Any long bones there? These are flat, right? Technically, even though they're curved, they're still flat. What about your ribs? They're kind of long and skinny, aren't they, long bones? Don't they articulate front and back? They do, but they don't have a shaft. They're flat. They're flat in profile. So they're flat bones. Even though they're long, skinny, and curved, they're still flat bones. Okay, sternum, clearly a flat bone. What about the scapula? You want to call it flat because it's got that big blade, but a true flat bone has to have spongy bone on the inside. So technically, scapulae are irregular. I have seen them classified in print as flat bones, but they're irregular. Scapulae irregular. Okay, so clavicle, does it have a shaft? If you cut it open, is it hollow on the inside like a good long bone? Yeah, it is. Does it articulate at its end? Yes, it does. So it's a long bone. It's the only long bone that's not in a limb. It's in a girdle, but it's not in a limb. Okay, so you think about all your other girdle bones. We address scapula. What about the hip bone? That's the only other girdle bone there is. How do you classify that one? Hip bone? Y'all haven't gone through your chapter summary yet. It's right in there, right? Some of you have, I know. It's irregular. That's what we said. Okay, so then you've got ribs, vertebrae, definitely irregular, wouldn't you agree? Yeah, so what's left? You've got some little facial bones. Some of them are irregular, the vertebrae are irregular. Some of the facial bones, no, pretty sure they're all irregular. Nasal bones are kind of problematic because they're definitely flat, but they're so flat, they're so thin, I'm not even sure if they classify as flat bones. Obviously, that one's not on the test, and so I don't remember it. Okay? So clavicle is just weird. All right? It's the only long bone that's not in a limb, and it is an intramembranous. At least the middle part of it is intramembranous. And there are other bones that are part cartilage and part membrane formed. The mandible, I think, is part and part. Did you know cats don't have a clavicle? That's just trivia, but I thought it. Okay, so that's kind of the story on intramembranous ossification. Make sure you know what tissue you start with. Make sure you know where in the body you are, and make sure you've got kind of an idea of what the different steps are. And now we'll talk about endochondra, which is a little more complicated because you can't just take cartilage and turn it into bone. What's wrong with that statement? Do the cartilage cells turn into bone cells the way mesenchymal cells turn into bone cells? You have to put the cartilage there, then you have to kill it. And then you have to get rid of it because it's solid stuff. You have to get rid of it and let the bone in. So we're going to start with a model of hyaline cartilage, and it's going to give you almost all of the skeleton. Okay, so you see on your list here, just the ends of the clavicle start out as cartilage. The middle part is fibrous. And we're going to go through long bone development because it's more complicated. The other bones do the same thing except they don't have a shaft. So what does a long bone have that a short bone doesn't have? It has that middle part. What's the proper term for the shaft of the long bone? Diaphysis. Okay? So we're going to have cartilage first, those chondroblasts get that growth factor signal, whatever it is, where they're sitting in their mesenchymal matrix, and somewhere in the 8th to 12th week of development, that signal starts to be secreted. I don't have a clear idea of what it is, but I want you to try to visualize this, particularly when we look at the pictures, because, let me see, I think I skipped a slide. Nope. Because you got to think small when you're thinking about embryonic development. Okay, that cartilage is going to do some weird things. It's going to form this nice, healthy cartilage, and then the pH is going to change in its matrix, and that pH change causes calcium salts to be deposited, so it calcifies. Now, remember, cartilage is avascular, right? So if you harden its matrix, you prevent the diffusion of water in and out. What's going to happen to the cells? You've cut off their connection to the body fluids, the nutritive fluids of the body. The cells are going to die. Well, when they die, they attract osteoclasts. So all your outline tells you here is that you get calcified cartilage shaft with large holes. Doesn't tell you where the holes came from. Osteoclasts, the bone-breaking cells, migrate in. They love calcified stuff. They're attracted to that. So the next step, and I think that the order of these may be a little bit off, you have to have blood vessels growing, and those blood vessels are going to kind of trigger the development of bone. Bone is well vascularized and cartilage is not. So once the blood vessels appear, that's part of the signal that says don't put cartilage here, put bone here, because cartilage doesn't have blood supplies. So once the blood vessels grow in, that allows a route for the osteoblast to migrate in and to start making bone. And they're going to make what we call the bone collar, which is just around the shaft of the bone. So let's just draw a quick sketch of that. Just a very quick sketch. And here we're just going to draw sort of a long bone with the epiphyses. That could be a That could be a phalanx, a little digit bone. Could be. All right, so if this is cartilage at this point, then the first thing I need to do is introduce a blood vessel. And when I get that blood vessel coming in, and it's going to come in at about the midpoint of the shaft, right? Because that's where the nutrient foramen is. As that blood supply branches, and it's just, think three-dimensionally, it's just in that layer around the outside, then at that point, the cells around it are forming bone instead of cartilage. So there's my collar, okay? The rest of this thing is still cartilage at this point. So this is all still cartilage. What's it doing? It's a solid cartilage matrix all the way through the shaft and everything. And it's doing that interstitial growth thing. Okay? So what happens to the size of this bone? It gets bigger. So it gets longer and it gets bigger around. And that process is going to continue as we get through all our ossification. Okay? What happens to our blood supply? It continues to grow, not just up and around, but also within. And when it gets to the inside, it accelerates the death of the cartilage in there. So when I accelerate the death of the cartilage, what I get is a thicker, bony collar around the outside that continues to grow and grow. But what about in the middle? What happens in the middle? In the middle, I got nothing. I got a cavity. Okay? So that's what long bones do that none of the other ones do. Okay? So can you name the two parts of a long bone that we just talked about that you don't see on any other kind of bone besides the long bone? The shaft, the collar is just the initial stage. Okay? The shaft and the cavity. The shaft and the cavity are found only on long bones. And that process continues. It gets thicker. The cavity widens as the osteoclasts brought in by the blood supply continue to grow. You get the invasion of that cavity with the marrow cells, which at this point are probably the blood-forming cells, the red marrow cells. They're all going to migrate in. Only in a long bone so far. Okay? So what's going to happen next? I'm just going to go ahead and show you in my picture, so that then when we get back to the text, you'll have a picture in your heads to compare it to. I'm going to get another blood vessel growing into first the proximal and then the distal epiphysis. And I'm going to repeat a lot of what I just did, except I'm not going to put a cavity in the ends. That only goes in the shaft. So my cartilage here is going to start to die. Why is it dying? I've got osteoclasts being brought in. I've changed the pH when I brought a blood supply in. And in there, what I'm going to do is replace it with bone. So I'm going to get bone right in here. And then later, here. So everything that's still white in my picture is cartilage. Okay? So I have bone here. I'm going to get bone forming across the marrow cavities. And I'm going to have bone forming in the epiphyses. But I'm still going to have cartilage on either side of the epiphysis, of the ossification center. Okay? So we have two different places, technically three, that we're ossifying. Our primary ossification center was here, right? In the shaft. And then we call the epiphyses the secondary ossification centers. Okay, so let's pick up where we left off. We got our bone collar formed, right? we get this little bud that starts to form, periosteal bud. It's going to bring in the blood supply and the osteoblasts. Those osteoblasts are going to give you your primary ossification center. Where are you in a long bone if it's a primary ossification center? In the middle, which is the shaft, the diaphysis. And then most of those have started by about the 12th week of development. And then you're going to do the epiphyses later. Okay, cartilage degenerates, osteoclasts remove it, and then it's going to be replaced by bone. So our secondary ossification centers in the epiphyses. The bone is going to displace the cartilage as it did in the shaft. The difference is we're not going to have a hollowed out medullary cavity, not in the middle of the epiphysis. Instead, what we're going to have there is spongy bone is going to persist. Okay, so again, looking at the end of a bone, where do I have cartilage left? I've got bone in the middle, right? And I've got bone on the shaft. So I have cartilage on the surface, and I have cartilage in between my primary and secondary ossification centers. Okay? The cartilage that's on the surface persists. That's your articular cartilage. And it stays, we hope, lifelong. If you lose that, you've got osteoarthritis, which is degenerative joint disease and can cause the bones to actually fuse together, and that's not a good thing. And then between the diaphysis and the epiphysis, we have the epiphyseal plates. Did you learn about those in lab? Yeah, so you know that's the growth plate. We talked about that yesterday. What's happening in the growth plate, of course, is the cartilage continues to add more and more to the length of the bone, and that's an interstitial kind of a growth, whereas the bone itself is getting thicker by appositional growth. Okay? Epiphyseal plates undergo a particular timing, so there's some pretty standard dates at which ages at which certain plates are going to disappear. And, you know, there's some variability from one person to the next. But the last plate to start ossification is the distal tibial plate, and it doesn't even start until your baby's 2 years old. Okay? So up until the age of 2, that little ankle is still pretty much cartilage. That's also the last one to finish ossifying, but at least the last one that adds to your growth in height. And generally that's by about age 18 in males and 16 in females, somewhere around there. So you're probably pretty close to the same height you were at about the age of 16. You might have grown a little bit, but not a lot. Most people. We use that information forensically as well, don't you know? So if they find skeletal remains and they're trying to date them to determine how old the person was at the point of death, that's the kind of thing they look at. Okay, so here are the diagrams out of your book, and I do want to point out in this picture, this is at 10 weeks. The technique that is used here it's not just used on humans. You can use it on embryos of various types. The stain they've used stains the calcium, the calcified tissue, which is going to be mostly bone. So they have a red stain that binds to the calcium, and then they use a protein digesting enzyme that just gets rid of everything else. So all you're seeing is the outline of the body, just a completely transparent little thing. And if that's 10 weeks, how big is it again? Maybe that big? Little tiny thing, okay? So you're looking at a cleared and stained fetus. And if you look at what's present and what's absent, look at the frontal bone. It's pretty clear, right? The parietal bones, not so much. They haven't developed as much. But look at the back of the head, at the base of the skull. Do you see that dark red occipital bone? That started as cartilage. That part of it started as cartilage. The jaws, upper and lower jaws, very evident at this stage. Again, cartilaginous growth. The vertebrae are in pieces. They haven't fully fused yet. Look at the forearms and the hands. And notice that the wrist is like invisible. What does that tell you? Hadn't started to ossify yet. Okay, and then it's kind of cut off in the picture. You can barely see the hip bones. How many ossification centers are there in a hip bone? 3. How do you know that? That wasn't just a lucky guess. That was an educated guess. How many bones make up the hip bone? 3. So you have 3 ossification centers, and they form as 3 separate bones that eventually finally fuse into one. Okay, so you can take a look at that diagram in your book to pick up some details. All right, do bones stop growing once you've reached your mature adult height? No, they do replacement. Now, how fast do your skin cells replace? 3 weeks or so? 3 or 4 weeks for your intestinal lining. How about your bones? How fast do you replace those? They don't slough off, right? There's no surface for them to slough off 1, 2. You need the osteoclast to come in and pull them out. And it turns out that some replace faster than others. If it's a part of the body that has a lot of pressure applied to it, like the ends of the long bones, then they get replaced more frequently. The slowest that I know of is the shaft of the femur. The shafts of your bones just don't recycle as much. They're not put under as much strain as the ends. The shaft of the femur is not fully replaced from when it first formed until you're in your mid-50s. So it's got a more than 50-year turnover cycle just to replace the bones of your femur. Okay, or the bone cells of your femur. So we're going to grow in length, of course, and we're going to grow appositionally as well to get thicker. We're going to focus very briefly on the epiphyseal plates, and I'm not too worried about the names of the layers as I am about the picture, which, there it is, skipped it. All right, so what I want you to see in this picture is the way the cartilage grows. In this area of proliferating cartilage. Notice that as the cells divide, they're almost all dividing top and bottom. They look like little stacks of coins, don't they? So it's making if this is the epiphyseal plate, then watch as I draw the new layers. They grow on the top surface. So I'm going to add new layers to the top. At the same time, I'm removing these layers at the bottom. It calcifies, and my osteoclasts are erasing it. So I am deleting the bottom at about the same rate that I'm adding new layers at the top. I'm erasing layers from the bottom, replacing that with bone, of course. So the epiphyseal plate itself stays pretty much the same thickness, but it only does it because I'm adding new layers at the top at the same rate I'm erasing old layers at the bottom. Does everybody understand how that works? Questions about that? You'll also notice, though, that sometimes they do divide side by side, and that will increase the thickness as well as the width as well as the thickness of the epiphyseal plates. Okay, so review those layers, but if you have any questions about how it grows the way it does, you can ask me. There's a kind of fracture that affects the growth plate. It's called a fracture of the growth plate. Okay, but what would happen if I broke the bone right across there? Ooh, that's bad, right? So particularly if you do it at the ankle, which is a pretty common place to injure a long bone. If you do it at the knee or the ankle, and you're hitting the tibia but not the fibula, or vice versa, what have you just done? What's that going to look like if you continue to grow? I had a student once that had this happen to me, and he came up and told me that after I gave this little lecture. He had fractured his tibia, the distal epiphysis of the tibia, but not the fibula. So that's the way your tibia and fibula sit. Very bad drawing, but there you go. Can you figure that out? Okay, so what if I fractured this growth plate but not the other one? What's going to happen to my tibia? It's still going to grow at the other end, so it's going to get taller and wider. But it's not going to grow anymore at this end. But what about my fibula? It's going to continue to grow. So what does that do to the way my foot sits? And it causes a limp as well, because now this leg is shorter than the other leg as well. So epiphyseal plate fractures are always taken seriously, or should be. And yeah, he wasn't happy that his dad told him that was too bad. He was just going to have to live with it. Yeah, because it's hard to go back and fix that later, don't you know? How would they fix it later? What would they have to do later? Anytime you have growth inhibition of a long bone, the only way to fix it is to break it and put extenders in there and then, encourage it to grow. So they do that in cases of dwarfism. If it's severe, they'll do that. And in a case like his, that was what his choice was: have surgery, have the bone rebroken and extended, or just live with a limp. And in his case, it wasn't that severe. He was just mostly irritated more than he was impeded. Okay, so the epiphyseal plate, absolutely essential for growth and length of the long bones. And we'll talk a little bit about what causes it to disappear when it does. But I also think you ought to know you have an epiphyseal plate at your mandibular condyle. You still have one there. And it just sits there. It kind of goes dormant and doesn't grow much. So even while you're still getting taller, that one stops growing. And it just sits there as a little epiphyseal plate that's dormant, sort of asleep at the wheel. And unless you have hormonal imbalances later in life, it's not going to bother you. But if you ever wake that up, what's going to happen to that plate right there? Your whole mandible is going to grow. It's going to elongate the rami, the branches, and it's going to cause your lower jaw to jet forward. Does that make sense to everybody? So there's a hormonal condition that occurs in, and we'll talk about that. Okay, what do we see in this x-ray? Are the epiphyseal plates apparent in the x-ray? Yeah. Okay, so you can tell if you, I have a chart. I keep it in my office so that I can tell. If I know where the epiphyseal plates are, I can age the skeleton. In fact, one of the skeletons that we acquired most recently was, I dated it to a 16-year-old female. And the way I did that was the epiphyseal, the epiphyses of the femurs were not attached. They were separate. So when they treat these bones, when they preserve them for educational purposes, they remove all that cartilage. The cartilage is all gone. And what's left are these bones. So did y'all get to see that one in lab? We have it in one of the two rooms. Yeah. So if you want, remind me to show it to you if you want me to, or ask your lab instructor. All right, so what is appositional growth? That's adding new layers. And the only place you can do that on the surface of a bone is on the outside, which is what that periosteal layer is doing. It's making the bones grow thicker. Okay? When you look at the growth of a bone, then what you see is that throughout your life, you're going to have remodeling of the bone. And that's kind of what I was talking about when they fix the roads right, they remove the old before they lay down new. You're doing this at a microscopic scale. So you may have a whole little osteon that your osteoclasts are busy eating out. They're not going to hurt the blood vessels, and they're not going to hurt the layer of osteoblast that lines the haversian canal. The central canal has osteoblasts there, and they're just going to be activated to make brand new bone in place of the old bone. But you do that lifelong, and you do it at a microscopic scale. And if you've ever had a bone break, then that remodeling will be shifted into a new direction, perhaps. If you have a bone that's not set well and it heals at an angle, that may cause all your little haversion systems to realign. They'll align with the mechanical stress of the bone. So it looks like you replace about 20% of your skeleton every year, and we're going to have hormones that are going to hormones and some kind of growth factors that are going to determine how that's done. Okay, so we'll talk about the primary hormones that affect the growth of the skeleton and what else to start with besides growth hormone. So for each of these hormones, you're going to want to know some information. For each of the hormones on this list, you need to know what gland secretes it. You need to know whether it's a protein hormone or a steroid hormone or something else. You need to know what it does, and you need to know how it's regulated. Okay, so far? So let's see if we can do that for growth hormone. Does anybody know what gland secretes growth hormone? Anybody? Which part of the pituitary? Anterior pituitary, which is a separate gland than the posterior pituitary. So let's make sure we're always specific about that. Anterior pituitary. Is it a protein hormone or a steroid hormone? It's actually a protein hormone. It is, it is, it is. Protein hormone. What does it do? We can read that off the screen. Growth hormone has at least two effects that you should know, just sort of two categories of effects. One is it stimulates the liver to secrete liver hormone, which is called somatomedin, which means the middle guy. And somatomedin has a host of effects throughout the body to stimulate growth. And the other is that growth hormone can directly stimulate the growth of cartilage. Not just in the epiphyseal plate, but cartilage in general is stimulated to grow. So tell me what the effect of growth hormone is on your adult height, your stature. It stimulates epiphyseal plates. Those are the things that make you grow taller. So if you have a deficiency of growth hormone, what condition will result? If you're abnormally short, that's called dwarfism. And if it's due to growth hormone, we call it pituitary dwarfism, because there are other causes of dwarfism besides an insufficient response to growth hormone. What would the opposite be? Gigantism, or it's sometimes called giantism. And if you want to be very precise, you would say pituitary giantism, but I don't know of anything else that causes it. And we'll worry later about the other effects of growth hormone. Right now, we're just looking at the skeleton. Next semester, we do the whole endocrine system. So when we do, we'll get to the rest of that. Okay, thyroid hormone. What gland secretes it? This one's tough. That's a trick question. Thyroid gland. What kind of hormone is it? Protein, steroid, or neither? It's actually neither of those. Thyroid hormone is an amino acid derivative. It's not a protein, but it's not a steroid either. It's kind of in its own little category. So what's its main function? Yes, you can read the screen for this one. It actually stimulates metabolism. It increases your metabolic rate. Now, I know we went over this already. It causes mitochondria to kind of waste ATP. It's not really a waste. You're generating body heat, which helps you grow. And it also stimulates the production of proteins within cells. And so it's just important for growth. So again, what's the impact on the skeleton if you are deficient in or deficient in thyroid? You have hypothyroidism. Skeleton fails to grow. And so you may have someone who is very stunted in growth, someone with untreated hypothyroidism from childhood, maybe only 3 feet tall as an adult, 3 or 4 feet tall as an adult. Okay, again, there are other factors that are going to come into play. It also affects nervous system development, which growth hormone does not. So if you have someone who has short stature due to hypothyroidism, they tend to be profoundly mentally retarded as well. Their mental age matches their height, 3 feet, 3 years old. Okay? The name of that condition is just called congenital hypothyroidism these days. What does congenital mean? You were born with it from birth, basically, or from the point before birth. Okay, there is an older name for this. I'm going to teach it to you so you know not to use it. So cretinism, it used to be used, I taught cretinism for years. That was the term we used. And then it was decided it's just not politically correct anymore. It's an offensive term. And part of the reason for that is simply the origin of the term. And I don't know what the rest of it is. It's just one of those things. So cretinism does not mean that the people that were born on the island of Crete are all idiots. That's not what it means. It comes from the French spelling of Christian, because to call someone a simple Christian was to say that they were basically incapable of sin because they were simple-minded. That's the term that was used. And so the term cretinism is actually derived from that. And so it refers mostly to their mental state and not to their stature. Okay? So now that you've heard it, can you remember not to use it? Let's see. Okay. Do sex hormones affect your skeleton? Do you remember going through a growth spurt when you hit puberty? I'll bet your mother does. Speaking as a mother. My younger daughter, who's 5'10", I think she grew 6 inches in 1 year. Do you know how many pairs of jeans you have to buy for a 16-year-old? Oh, my gosh. Okay, I'm sure you do. All right, so if we graft the increase in height throughout your lifespan, if we're graphing age over height, then, of course, when you're a baby, we would just stretch you out and take from heel to the top of your head. And what do you think is going to happen as you get to about the age of 10? You just get taller and taller and taller. And then if you hit puberty somewhere in there, between, say, 12 to 15, what's going to happen in there? You kind of shoot up. Not that much, but I'm trying to draw it big enough for you to see it. And then what happens? Then it kind of levels off until you get really old. Then what happens? Yeah, your vertebrae start to collapse and you actually lose some height. Again, this is exaggerated for the sake of seeing it on the board. If you have a kid who hits puberty early versus a kid who hits puberty late, I want you to, in your groups, to draw the graphs on top of this one. So here's the kid with early onset of puberty. Just use different colors or dashed lines or something. The kid with late onset of puberty. You're going to graph them up to adult height. Okay, so draw your own graphs See if you can figure out what that's going to do. I'm going to give you about 5 minutes to graph this. Okay, so what do you think? Compared to our normal graph, which is the black line, if the green one is the one that hits puberty early, and I'm not trying to indicate that they're shorter initially. They may or may not be. They may be right smack on top of the black. But when do they hit puberty? 10. Okay, 10 it is. So they get a growth spurt. Is their growth spurt longer, stronger, shorter? Same. So however long that black line is, this green line should be the same, but it starts when they are younger, therefore shorter. So they wind up leveling off as a shorter person. Does that make sense to everybody? Okay? Do y'all see why? All right, so likewise, if you have someone who has late onset of puberty, when do they hit puberty? 16? So they've been growing at that childhood rate longer. But then they hit that same growth spurt, only they start it when they are older, therefore taller. So they wind up being taller. Does that make sense to everybody? Questions about that? This actually, I don't know what they're doing these days. My kids are grown, so I haven't paid that much attention the last few years, but I used to pay attention to it. And I do know that sometimes, especially tall women who are 6 feet or taller, generally the ones that I know of report that they hit puberty late. So, and in some cases, their doc was saying, we can go ahead and put you on hormones or put your kid on hormones. One of my colleagues actually, who taught here when I started, she was over 6 feet, and one of her daughters was over 6 feet. And she was telling us, because we were talking about how we teach this stuff, and she was saying, yeah, the doc said he'd start her if I wanted. And I'm like, no, it's genetic. I'm tall, she's going to be tall. This is why we're tall, is because of late onset of puberty. So it's not just tall genes, it's actually those genes have to operate in some way or another, and that happens to be one of the ways that they operate. Yeah.
So if you didn't do hormones early, would that just start puberty?
In effect, that's what he was doing was it was just going to start it earlier, force it to start earlier hormonally.
Just like trick the body into starting.
Exactly. Well, it at least would have the skeletal effect. Whether it would get your brain kicked into gear, I think that's beyond what I know. I would be nervous about giving a 16-year-old girl hormones. Now, we do that, right? Y'all know that we put young ladies on hormones. We put them on birth control pills, basically. Usually it's because of severe acne, and that does seem to help. I have no comment on what other effects it may have putting a 16-year-old girl on birth control. I'm not going there. It makes them crazy? I thought it calmed them down. Not necessarily.
Have so many of them that change, each week it's a different color, and that it has different type of hormones, and they're terrible.
Really? Okay. I'll take your word for it.
Okay.
Okay. So in females, the sex hormones are called the estrogens, and in males, they are the androgens, and the main androgen is testosterone. So something stimulates the secretion of these hormones in increasing amounts at the beginning of puberty. And the thing is, there's a two-edged effect to these sex hormones. When you first start to secrete them, low levels of sex hormones accelerate the growth of the epiphyseal plates, and you get that growth spurt. But when you finally plateau at adult levels of the hormones, high levels of those hormones inhibit the epiphyseal plate. The plate quits growing, the bone takes over, it completely ossifies, and the plate is replaced by the line. Okay? Everybody understand the basic process? Questions about that? And what is the only plate that I know of, that I've already told you, that doesn't happen to? Mandibular condyle. The epiphyseal plate there just goes dormant. It doesn't ossify. Don't know why, but it doesn't. You may be 25, 30 years old before it finally ossifies. And there is a condition called, might as well go ahead and do it, acromegaly. Which is an excess secretion of growth hormone after you've reached your adult height. So if you start to secrete growth hormone, what if it happens at age 16 versus age 25? What's going to happen to a 16-year-old that's not going to happen to a 25-year-old if they start secreting growth hormone excessively, usually a pituitary tumor? Yeah, you'll get a little bit taller. Maybe not a lot taller, but some. Yeah. So you're just a big person. You're gigantic. The jaw elongates, as I said. You still get appositional growth. What did that mean? Thickening of the bones. So the finger bones, the hands can get as big as the blade of a shovel. That's how much growth they can have. Thickening of the brow ridge. Elongation of the jaw, thickening of the occipital protuberance. Don't forget, growth hormone also causes growth of cartilage, nasal cartilage, auricular cartilage. So ears get big, nose gets big, hands get big, feet get big, so do your internal organs. So you have enlargement of the organs. You also have trouble regulating blood sugar because growth hormone also stimulates an increase in blood sugar, so you have effects like diabetes. Overall, it's not a good condition to have. So let's stop for a sec, and let's think about where the heck is your pituitary gland? So if here is your brain, your pituitary sits at the base of your brain. Okay, where is your skull in relation to that? There's your cranial case. Here's your face, more or less. So if I want to surgically remove a tumor that is sitting on my pituitary, I've got this tumor here. How am I going to get to that? They go through your nose. They do. That sounds horrible to me. They actually go under your upper lip so that there are no scars. They'll go up under the lip to get into the nasal cavity. So the first incision is up under your lip, through the nasal cavity. What bones are in there? This is not drawn very well, obviously. I need a cribriform plate here. I need an ethmoid bone. I've got a perpendicular plate. I've got to get through all of that. So they're going to drill up through the nasal cavity to get to that pituitary tumor. Hopefully it's a benign tumor, right? What did that mean? Got a nice capsule around it, they can just pull the whole thing out. They may, in fact, remove your pituitary, or at least the anterior lobe of your pituitary, the whole thing, and then supplement the hormones that you no longer produce because they remove the whole thing. They're going to pack your nose with gauze. Just shoot me now. Just can't imagine having I had a friend that had that happen. She said it was just like she was on pain pills, like the whole. Once she woke up, nasal passages packed with gauze. Yeah, I just have trouble imagining that. But she was much better. She was, after that. After she got over that, she was fine. What?
How do those tumors get, like, does it happen naturally?
You could say it's natural, but it's abnormal. I mean, tumors in general are not a normal thing. But you can have a pseudotumor, too. What does pseudo mean? False. And in a pseudotumor, you've got excess fluid in that little indentation. Y'all know what that is. It's the sella turcica of the sphenoid bone. Y'all learned that in lab, didn't you? Sella turcica is where the pituitary sits. It's a little cradle of bone. So if you had fluid accumulating in there, it would put pressure on the pituitary, and that pressure could cause problems. So, but yeah, it just grows. Just a mistake in the cell division. Okay, so those are primarily the hormones that are involved in the growth of bones. What were the 3 categories of hormones we just looked at that are involved in growth of bones? There's growth hormone, there's thyroid hormone, and then there are these sex hormones, right? I'm mentioning serotonin because your book does. Serotonin is a chemical messenger that is found in unexpected places doing unexpected things. Serotonin is a neurotransmitter in the brain, and so we'll talk about it when we get to the nervous system. Serotonin is involved in a lot of mood-related conditions of the brain. It's a mood elevator. It helps regulate your wake-sleep cycle. Too much of it can cause hallucinations. It's got all kinds of things going on in the brain, so we'll worry more about that later. But it is interesting to note that bone cells have serotonin receptors. What the heck is going on here? I don't know. All I can tell you is they're there and that they seem to be playing some role in regulating rate and regulation of normal bone remodeling. They're talking to the bone cells. And the reason I want you to know about this is that serotonin is one of the neurotransmitters that at least appears to be influenced by diet. Okay? So if you're on one of those highly regulated weight loss diets, then you may be influencing your serotonin levels. And serotonin is one of the signals that is involved in regulating appetite. So some of the diet drugs that have been used in the past were drugs that impacted serotonin levels. They were selective serotonin reuptake inhibitors. Did you get that? SSRIs. Selective serotonin reuptake inhibitor. And we use SSRIs as antidepressants. We use it to treat attention deficit disorder. We know that there are different kinds of serotonin receptors. There's at least 5 different ones in the brain alone. I have no idea what's going on in the bone cells. No idea. But I know that serotonin levels are impacted by diet. So, and by extension, insulin helps to regulate them. So it will help you to understand what insulin is doing. What do you already know that insulin does? Lowers your blood sugar. Did you know it also lowers your blood amino acid concentration? When you eat, generally you're eating food that is of mixed content. You're not eating pure protein. Some of us eat pure carbs some of the time, but we probably shouldn't do that, right? Just saying. You should have a good mix of protein, fat, and carbs at every meal. Serotonin, through its influence on, or through the influence of insulin, serotonin levels are enhanced when you eat a mix of protein and carbohydrate. And the reason is, more or less, metabolically, that serotonin is derived from tryptophan, and tryptophan is one of the 20 amino acids, and it's weird and different than the others because it's not affected by insulin. So let's see if we can work through that. If you ate a peanut butter cracker, that's a good mix of protein, carb, and a little bit of lipid thrown in, and your blood sugar level went up, that makes your insulin level go up, right? What does insulin do to blood sugar? Brings it down. What does it do to amino acid levels? Drops them down, all except tryptophan. So now we have in the blood a higher level of tryptophan than the other 19 amino acids. When your brain is importing amino acids, excessive, not excessive, but more than the others, tryptophan will be imported into the brain through the blood-brain barrier. So tryptophan levels in brain cells go up. Brain cells then preferentially produce serotonin. So when you're hungry and you're restless or you're anxious or you're having trouble sleeping, then protein plus carb is a good mix because it'll raise the tryptophan levels, which by extension we hope will raise the serotonin levels, which will help you sleep. Okay, so when you see nutritional supplements that are sleep aids, anybody looked into those? Melatonin is the typical one. We associate melatonin with your daily cycle. But serotonin is, or tryptophan is the other. When we blame Thanksgiving dinner for putting us in comas, who are we blaming for that? It's tryptophan. We're saying that turkey meat is high in tryptophan, and we blame the tryptophan. So I don't know how scientific any of that is, but I know that at least some research supports it, and it's probably extremely individualistic. So more so for some people than for others. Okay, I know for me personally, if I eat a lot of bread, I get sleepy, especially for lunch. If I like a Subway sandwich with lots of, I love that stuff. It's so good. Bread is highly toxic stuff, I've decided. First of all, it's very addictive because it tastes so darn good. And second of all, it makes me crave it. And third of all, it puts me to sleep. So, just saying. So, high protein, low carb lunch doesn't have that effect on it. All right, so that's what we know about serotonin. And if you have chronically high levels, it can inhibit bone growth in some way or another. Oh, it did skip, I'm pretty sure. Okay, so we're going to move on as soon as I can get my thing to respond adequately. We're going to regulate not bone growth. We're going to regulate blood calcium levels. Now, let's all be reminded, what are the 4 things in my body that need calcium? Is bone at the top of the list? It's at the bottom of the list. What's above it? Not necessarily in any specific order. Nerve cells, muscle cells, and blood. So if I don't have calcium for my nerve cells, they'll not stimulate my other cells. They won't stimulate other neurons or muscle cells. Generally speaking, that's not going to happen. Okay, you're not going to have a calcium deficiency that's going to do that. You're going to have other problems first. The muscle that's affected primarily is the heart. So if you have a calcium deficiency, the heart doesn't beat strongly enough. Again, it's really hard to be that low in calcium. But we definitely need calcium for blood clotting. In fact, when we store blood that's been donated, we store it by adding to it something called sodium EDTA. And the sodium EDTA is, first of all, it's ionic. You know that because it has sodium in it. The thing about EDTA is it prefers calcium. So when you add sodium EDTA to a bag that's been donated, it swaps out the sodium and grabs all the calcium. So the calcium's all tied up. Can the blood clot without calcium? Cannot. That's what it needs calcium for. Calcium's absolutely essential for blood clotting. Okay? So one of the ways that we prevent stored blood from clotting is to soak up all the calcium. If you donate just double reds, any of y'all done that? You should do that sometime. It's a very interesting physiological experiment. So first of all, you can only donate half as often, and second of all, they use a smaller needle. That's why it's my favorite. It's a little bit longer to donate, but not that long. So what they do is they take the blood out, and they run it through a machine that separates the red cells from the plasma, and then they give you the plasma back. But in the process of doing that, don't they have to add an anticoagulant to it to keep it from clotting? Yeah, so when they add that plasma back to you, they're giving you a little bit of anticoagulant. You do want to watch your step for a little while after that. But what I notice when I do it is it makes my lips tingle. And then it makes the muscles in my mouth start to twitch. What's going on there? It's removing calcium. And as we'll see when we get to the muscles, that makes muscles twitchy. It's needed for muscle contraction, but it's also needed to regulate contraction. So hypocalcemia, low calcium in the blood, actually causes muscle spasm. So if you're going to donate, then you can tell them if that's happening. They usually keep a little pack of Tums. Why do they do that? That's got calcium in it, so they're just going to give you a couple of Tums to chew, and that'll give you your calcium back. Just a handy tip. Okay, so how important is it to regulate blood calcium levels? Oh my gosh, we just have to keep them in the normal range. You need it for muscle contraction, you need it for secretion of any cellular secretion that includes neuron secreting neurotransmitters. You need it in the heart for regulating contraction, you need it for blood clotting, and we have two primary hormones that regulate calcium in adults, calcitriol, also called calcitriol, and parathyroid hormone, which we're going to abbreviate PTH. So you need to know, here's two more hormones, and we'll get a couple more, at least one more. You need to know what gland secretes them. You need to know what the stimulus for secretion is and what they do. So can you tell me the name of the gland that secretes parathyroid hormone? That's a trick question. The parathyroid glands. Where would they be if they're called parathyroid? They sit alongside the thyroid. In fact, you have 4 of them, and they're embedded in the back side of both of your lobes, upper and lower. Calcitriol, we'll see, is a complex hormone that in its final form is actually secreted by the kidneys. But it starts out as vitamin D. So is it a protein hormone or a steroid hormone? We already know the answer to that, right? Vitamin D is a steroid. It's made from cholesterol. So we learned part of this story when we were studying the skin. Ultraviolet light in your keratinocytes stimulates the conversion of vitamin D, of cholesterol into vitamin D. Vitamin D then gets into the bloodstream. It goes to the liver next, and the liver is involved in one stage of the secretion. And then it gets back in the bloodstream and goes to the kidneys. So here are the steps I want you to know. Cholesterol to vitamin D. Where did that occur? That's in the skin. And then it goes to the liver, and then it goes to the kidney, where it's converted to calcitriol. I do not ask you to learn the intermediate terms, cholecalciferol and calcidiol. I don't care. So vitamin D to calcitriol, skin to liver to kidneys. Okay? As a steroid hormone, think back to what we said about cells that secrete steroids. They kind of produce them all the time. So it's a chronic and continual production of calcitriol. You can speed it up and slow it down. The main thing that slows it down is not enough vitamin D. But we also know that parathyroid hormone speeds it up. Okay? So if I need more calcitriol, I got to have the vitamin D, which can come in through my UV radiation or through my diet, either one. But I also need parathyroid hormone to goose it into a higher level of production. Okay? So vitamin D is regulated partly by diet, partly by exposure to UV, but definitely by PTH. What regulates PTH? Let's see. PTH comes from there's our picture of vitamin D. Come on. PTH secreted by the parathyroid glands in response to reduced blood calcium levels. Okay, so if we were going to abbreviate this, this is the physiology I promised you. When your blood calcium level, concentration of calcium drops, remember the brackets indicate concentration, what happens to PTH? It increases. What happens when PTH goes up? That causes you to produce more calcitriol. And PTH plus calcitriol stimulates 3 organs. Do you see what they are? Bone, kidney, gut. What's happening in the bone? Tell you what, let's do this in our groups. Knowing that the stimulus was my blood calcium dropped too low, you tell me what PTH and calcitriol do to bone, kidneys, and gut. Okay, just 3 statements. Boom, boom, boom. What's it going to do to bone? What's it going to do to the kidneys? What do the kidneys have to do with it? What's it going to do to the gut? Just as an obvious first step, we're doing negative feedback here. Okay? So your stimulus is your blood calcium dropped. What does your response need to be? You're doing negative feedback. You better bring it up. So what are you going to do to bone to bring it up? What are you going to do to the kidneys to bring it up? And what are you going to do to the gut to bring it up? Does that make sense? Not looking for specific mechanisms, just big picture ideas. Tell me about convoluted tubes. What do your kidneys do? What do they make? Okay, so just put it in those terms. Focus, you guys, is on the blood calcium. We have to bring the blood calcium up. So what do I do to my bones to put more calcium into my blood? What is my gut doing to put calcium in my blood? What are my kidneys doing to put calcium in my blood? Okay? Refocusing on the question. problems that we, as faculty, have trouble with is getting you, not y'all, of course, y'all would never do this, but, and, yeah, no, but other people's students will say it regulates, the liver regulates it. Well, okay, great. What is it doing? Is it increasing it or decreasing it? Be specific. So what do we need calcium to do? And let me turn my recording back on before we get too carried away. Oh, I did never turn it off. Yeah. Yes, I did. No, I didn't. Hope y'all aren't listening to all this stuff. Okay, so what do we need? What are we trying to do here? So if our calcium levels dropped, that's our stimulus. Then at the very end, we want them to go back up. That's our response, right? Okay, so this causes the secretion of PTH, which stimulates an increase in calcitriol, as we've seen. And together, these things will talk to the bone. What are they going to tell the bone? Let my calcium go. Let me have it. Okay? So which cells do that? The clasts. And so you break down bone, and that releases calcium to the blood. So if I ask you, does PTH increase or decrease bone calcium, what's the answer? It decreases bone calcium because it's taking it out of the bone and putting it into the blood. Does that make sense? Clear? Okay. What is it going to do to the kidneys? Kidneys make urine. Urine contains all kinds of things, including calcium. So it tells the kidneys, hold the calcium. Don't let it go. And consequently, blood calcium increases because the kidneys hold on to it. By the way, caffeine, you know, has a diuretic effect. You knew that, I'm pretty sure. Yeah, it inhibits calcium reabsorption. So if you are a caffeine addict to the extreme, you might want to boost your calcium intake. Just saying. Okay, and then calcitriol, which, because it's stimulated by PTH, talks to the gut. What do you think it's going to tell the gut? If there's any calcium in that food at all, you be sure to absorb it. Okay, it increases the absorption of calcium from the gut. And that then is going to increase the blood calcium. So you increase absorption of calcium in the gut, the reabsorption of calcium in the kidneys, and the removal of calcium from your bones, all of that to boost blood calcium levels. Do everybody see how that all goes together? So that's a physiological mechanism that is hormonally regulated. Let's see what happens. Hey, I can still record. I'll come back on in a sec. We'll take a short break while we wait for our equipment to come back up, including the internet.